It doesn't do any good to talk about these outrageous cases, right, without there being some solution. And I will always talk about a case and then follow up with what a solution could be to the... I've got another interesting case for you guys. So let me first start by saying of 6,120 hospitals in the United States as of the data today, January 2025, not everybody is accredited by Joint Commission. So of those 6,120 hospitals, 1,300 right now are not accredited. What that means is the Joint Commission comes up with some universal protocols, for example, like we're going to talk about again, the timeout, pause, or checklist protocol that's done before every procedure or surgical intervention in the United States. But those hospitals that are not accredited do not have to follow these guidelines that are given, universal precautions and other guidelines and protocols given by the Joint Commission. I talked about wrong site amputation of a gentleman's lower leg in my last video. So today I want to talk about a lovely lady named Regina Turner. A surgery was performed called a craniotomy on Miss Regina Turner's wrong side of her head. Now, her hospital was accredited, so what continues to go on here? We know that doing these timeouts really help, that they have made a significant difference in wrong site surgeries, in death rates, and in litigation, but that's for the people that use them. So what happened in her case is that the surgical team did not do a timeout and did not do a checklist. When that checklist is done, stating that this timeout was achieved, that means everybody in the surgery room stops everything that they're doing. Everybody in the OR stops everything that they're doing. They pay attention to what is on that checklist. Is it the right patient? Is it the right surgical site? Has it been marked correctly? Are the needed equipment that might be used or will be used for this patient in place? Among many other things. The timeout protocol was mandated in 2004 by the Joint Commission. It's a universal protocol for preventing what I just talked about: wrong site, wrong procedure, wrong patient errors. It's mandatory for all accredited healthcare facilities to utilize this universal protocol. Reporting evidence shows that this is a simple yet very powerful tool. It's an intervention that improves patient safety and surgical outcomes. Why is it that some hospitals or surgical centers are not using it? Even in interventional radiology, they use it. It's supposed to be used everywhere. And just because a hospital isn't accredited doesn't mean that they can't implement this. It's just that they don't have to implement this. I'm going to put up some documentation of what the checklist looks like, and it can be different in a little bit different depending on the surgery. Some things might be added on. It can be different if it's a C-section versus a craniotomy. There's just, because of course different equipment and so forth is going to be used. But I'm going to give you an idea of what the universal protocol looks like. So I will put that up. In the meantime, I want to tell you a little bit about Miss Regina Turner. She had this done in 2013. She was scheduled for a left-sided craniotomy bypass to prevent future strokes. But instead, she had done a right-sided craniotomy by her physician, surgeon, neurosurgeon, Dr. Jonathan A. Cohen. He, at the time, was working at Yale New Haven Hospital. He was a prominent neurosurgeon. He admitted to this mistake. He felt terrible about this mistake, and he did face disciplinary action by the Connecticut Medical Examining Board. Now, he was fined, I believe it was a minuscule amount, $3,000. He had to go back for retraining, re-education on what the timeout protocol entails. However, it was only a matter of months, about a year that went by, 12 months or so, and Dr. Cohen resigned from that hospital, and he no longer was a neurosurgeon, from what I could find in all the documentation about this case. There's a lot of factors that go on. Why wouldn't the hospital implement this? But just, I'm going to say what happened, what went wrong. But I'm also going to say what we should be doing, us as patients, caregivers, family members. What can we do to help so errors like this are much less likely to occur? Factors that contribute to wrong site surgeries are not doing the timeout protocol, not doing the checklist, communication breakdown, distractions, interruptions, marking the wrong site. I'm going to talk about that in just a moment, like I did in my other video, about the importance of marking the site. Not just the surgeon doing it, but you, the patient, doing it, family members who are there, if they are there before the patient goes back for surgery. Everybody being on the same page, understanding by marking where that surgical site is going to be. Other errors that occur is that the patient doesn't speak to the surgeon before surgery. They are supposed to meet the patient before surgery begins. There's scheduler errors. The scheduler and the person writing on the operating room communication board or blackboard are sometimes might be putting the wrong foot down, the wrong side of the head down. And that leads, of course, to surgical errors as well. It can be stopped if an error on the board says right foot, but it's the left foot that's getting amputated. Corrections are in place if used to try to mitigate that disaster of follow through of the wrong foot, for example. When some distractions or interruptions occur, we think of it like, well, that's not really that big of a deal, but it is a big deal. And I can think of one very tragic case that occurred up at Seattle Children's Hospital many years ago, and I was working at a different pediatric hospital at the time. And this nurse, who was a seasoned intensive care unit nurse in pediatrics, gave a dose of a medication that resulted in the death of a child. Now, you think about, just like with this prominent neurosurgeon who went to school for, 13 or 16 years of his life, who maybe was a fantastic neurosurgeon, as she was a fantastic nurse. What was it that slipped that day when they know better? In her case, she gave the wrong dose. It was the correct patient, it was the correct medication, it was the wrong dose. And the error occurred, according to the documentation at that time, due to interruptions. And then protocols were put into place after that, because it not only led to the death of that child, which already had medical conditions that maybe weren't favorable for life anyway, and the child definitely didn't need this medical error, but what I'm saying is that child's condition could have resulted in him not having a favorable outcome for life, whether she did that or not. But when a nurse is in the medication room, it used to be everybody else was in there too. That was like the place to go to chit chat. You go in there and you connect for a few minutes. But she was interrupted quite a bit. When she was in there, she got distracted. She drew up the wrong amount. She gave the wrong amount of medication. Distractions are real. You think about when people are working and they are interrupted time and again, how many errors are occurring due to those, directly to those interruptions? Let's talk about some other factors. As far as Regina Turner, I could not find anything that said that her surgical site was marked. I had no, her head would have been marked. The surgeon would have gone over that with her. And like I mentioned in the other video as well, you know, when you're going in for surgery and they say, here you go, mark the spot, the patient has to be involved in this too. I'm marking this side of my eye. Oh no, surgery's supposed to be on that side, vice versa, whoever you're talking with on the team. The patient needs to be involved in what is taking place prior to surgery and before medication is given to that patient. Patient not being adequately informed about the procedure, not actively participating in the verification process, can contribute to wrong site surgery. Patients not speaking up, asking questions, or marking the spot of surgery. Those are some indicators of how errors can occur or can contribute to significant errors. So that's one thing that we can do. We can go to hospitals that are accredited because they are required to follow the protocol of Joint Commission. Whether they follow them or not, like in Regina Turner's case, one thing we want to do is that, you know, that's the best we can do. Go to a hospital that's accredited. Have a surgeon that's board certified or a provider that's board certified in their field of specialty. Participate in the conversation before surgery. Participate in marking the surgical site. All of this marking and conversation goes on before the patient gets medicated, before they're wheeled down into the OR. And then timeout occurs in the OR, and that means everybody in the operating room is participating in this, listening to this, and checking off that everything is correct before the incision, before anything begins. Regina Turner was at a hospital in Missouri. It was called St. Clair Health Center in Fenton, Missouri. It was accredited. They were required to do the timeout protocol. But this protocol and everything involved in it was not adhered to. In other words, the timeout pause checklist protocol that is worldwide now was not done. I looked high and low to find out why. Was there a reason? Was there a distraction? Was this kind of the norm going on, kind of the cutting corners? Why? Is this just one off, or was this kind of how things had been going at that hospital? I couldn't find any information specific to that. 2013, Regina Turner, St. Clair Health Center. Doctor, let me get his name right, Armand Levy. He was in his 50s, Miss Regina Turner, age 53 at the time. And then sadly, after this surgery, Miss Turner had to have 24-hour round-the-clock medical care. She was unable to speak or work, and she passed away in October of 2021. So what can we do as patients going into procedures, going into the hospital for surgery, choosing an emergency room? What we can do is go to one that is accredited and choose a physician that is board certified. And the last thing we can do is before you go in for surgery, and even prior to that, when you're speaking with your surgeon at that pre-surgical consultation, bring up these questions. I know it feels like I don't know enough, or I feel kind of stupid asking this, or I don't want to insult the surgeon. They seem so busy. I don't want to bother them. They might be thinking I'm challenging their authority. There's all those things going on. I don't know what to ask. It's okay to go in with a list. It's okay to ask step one from the very beginning. I'm just curious, are you board certified? Have you done a lot of these? What's the outcome like? It's okay to ask those questions. Just push past your fear and do it, because it's that important. And then before you go back for surgery, or even your endoscopy, your colonoscopy, anything, same thing. Ask a couple questions. Do you guys do a timeout pause? And when they ask you questions like, please state your name, your date of birth, your address, what site are we working on today? They're asking that many times over to ensure that you know. But it's important that that continues on all the way through to the operating room. But when they come in prior to surgery, we'll stick with, say, an operation, not a procedure. Yes, watch where the doctor is marking the spot. If the surgeon doesn't even come in to see you, ask for the surgeon. It's okay to ask for the surgeon. Maybe they're going to send their PA in who works with them. That's okay too, in my opinion, unless you want to speak to the surgeon, which is okay as well. But if the PA comes in, or nurse anesthetist, or the anesthesiologist should be in there, but the ARNP, whoever's working with that surgeon, could come in and talk with you, ask your questions, because they're going to be back in the OR with the surgeon. Watch where they're marking. Mark it as well. They usually put markings on and put their initials on, or they do some little scribble thing. It's different for each one, but the acknowledgement is there. It is my left leg. It is my right side of the face. It is my left eye, and so forth. Everybody's on the same page before going back to the operating room. It doesn't do any good to talk about these outrageous cases, right, without there being some solution. And I will always talk about a case and then follow up with what a solution could be to the best of our ability. And I also always list my resources below. I'm not going to tell you anything unless I have researched it myself first, and I can back it up by putting my resources. If you look further into description, that's usually where everything is listed, or I put a pop-up. So I hope this was helpful. Have a wonderful day. If you like this kind of information, or mishaps with medicine, myths and facts, or if you have a topic that you really are wanting to understand a little bit better, please let me know.